And then got a board game to hold the camera up, and then a 15-second timer, and light, and stethoscope. Hello, my name is Adobe Leonard. Today is July 9th, 2025. I will be conducting a cardiovascular and peripheral vascular assessment for nursing 518. This is my volunteer patient. Do I have your consent to start this assessment?
Yes.
All right, please lay down. First, I'm going to inspect the apical pulse. To inspect the apical pulse, I'm going to identify the apical impulse, also known as the point of maximal impulse, or the PMI. The PMI is located at the fifth intercostal space, just medial to the left midclavicular line. Since I'm only inspecting, I estimate that the PMI is in this area. I'm using tangential lighting at a 45-degree angle to inspect and observe any ventricular movements or pulsations. I do see some pulsations. Next, I'm going to inspect both the right and left jugular veins for jugular venous distension or bulging neck veins. I do not observe any bulging neck veins, but I do see some light pulsations. Next, I'm going to palpate for heaves in all 5 areas of the chest wall. Heaves are sustained impulses that rhythmically lift your fingers when you palpate. To palpate for heaves, I place my finger pads against his chest. To begin, I'm going to palpate the aortic area, which is located at the right second interspace. Next, I'm going to palpate the left second interspace, or the pulmonic area. Next, I'm going to palpate the right ventricular area, which is located at the left sternal border. Next, I'll palpate the left ventricular area, or the apex. And finally, I'm palpating the epigastric or subxiphoid area. I was able to palpate light pulsations in these areas, but no heaves. This is an expected finding. The presence of heaves could indicate an enlarged right or left ventricle, as well as the presence of increased ventricular workload. Next, I'm going to palpate for thrills, which are vibrating sensations caused by an underlying turbulent flow. To palpate for thrills, I'll firmly press the ball of my hand on the same 5 areas, beginning again with the aortic area at the right second interspace. Again, the pulmonic area, the right ventricular area. Now the apex, and finally the epigastric subxiphoid area. I do not feel any thrills of palpation, which is an expected finding. The presence of thrills would indicate a heart murmur. Now I'm going to auscultate for heart sounds using the diaphragm of my stethoscope to allow me to hear the high-pitched S1 and S2 sounds and any murmurs of mitral regurgitation. Using the bell allows me to hear the low-pitched S3 and S4 sounds and the murmur of mitral stenosis. So I'll begin with auscultating the aortic area located at the second intercostal space on the right sternal border. I'll begin by placing the diaphragm against the skin. I can hear high-pitched S1 and S2 sounds, no murmurs. Now turn to the bell. I hear low-pitched S3 and S4, no murmur of mitral stenosis. Next is the pulmonic area, located at the second intercostal space on the right sternal border. Back to the diaphragm of the stethoscope. I can hear high-pitched S1 and S2 sounds. Now for the bell. I hear low-pitched S3 and S4 sounds. No murmur of mitral stenosis. Next is Erb's Point, located at the third intercostal space on the left sternal border. We're back to the diaphragm. I can hear high-pitched S1 and S2 sounds. Now for the bell. I hear low-pitched S3 and S4 sounds. No murmur of mitral stenosis here. Next is the tricuspid area, located at the fourth intercostal space on the left sternal border. Back to the diaphragm. I can hear high-pitched S1 and S2 sounds. I'll listen with the bell. I hear low-pitched S3 and S4 sounds. No murmur of mitral stenosis. Finally, the apex or mitral area, which is located at the fifth intercostal space, medial to the left in midclavicular line, back to the diaphragm. I hear high-pitched S1 and S2 sounds. Now for the bell. I hear low-pitched S3 and S4 sounds. No murmur of mitral stenosis. Now I'm going to listen to the apical pulse to assess the rhythm. The rhythm of the apical pulse is regular. So now I'm going to listen to the apical pulse to find his heart rates. Since his heart rhythm is regular, I'm going to listen to 15 seconds and multiply that number by 4 to determine his heart rates. Here, go ahead and start your timer. Well, okay. I counted about 20 beats multiplied by 4, so that is a heart rate of 80 beats per minute. Get that out of here. Now I'm going to auscultate the left and right carotid arteries for bruits. Bruits are kind of a swooshing sound, and they can indicate vascular pathology. If bruits are present, they require care from a specialist. So to auscultate the carotid arteries, I'm going to place the diaphragm of my stethoscope on the upper end of the thyroid cartilage behind the lower jaw. I do not hear any bruits. Because I don't hear any bruits, I'm going to palpate for thrills. These can indicate vascular pathology as well. So I'll use my index and middle fingers and press the inside of the medial border of the sternocleidomastoid muscle. Cleidomastoid. I don't feel any thrills. Because I didn't detect any bruits or thrills, vascular pathology is unlikely. Earlier, I mentioned S1 and S2 sounds. The S1 and S2 sounds are created by the closure of the heart valves. S1 is the closing of the mitral and tricuspid valves, while S2 is the closing of the aortic and pulmonic. S1 is louder at the apex, while S2 is louder at the base. There are phases of the cardiac cycle referred to as a systole and diastole. Systole is the interval between S1 and S2, while diastole is the interval between S2 and the following S1. Systole is also the period of ventricular contraction when the aortic and pulmonic valves are open and the mitral and tricuspid valves are closed. Diastole is the opposite. So it's the period of ventricular relaxation, and it occurs when the aortic and pulmonic valves are closed and the mitral and tricuspid valves are open. Now we'll move on to the peripheral vascular part of the assessment. We grade pulses by using a scale from 0 to 3 plus. 0 is absent pulse, 1 plus is a weak pulse, 2 plus is a brisk or expected pulse, and 3 plus is a bounding pulse. So first, I'll palpate the radial pulses. So I'll use the pads of my fingers to palpate the flexor surface of the lateral wrist. Both pulses I would consider 3 plus bounding, but this patient does have hereditary hypertension, so that's expected. Next, I will palpate the brachial pulse by using the pads of my fingers in between his elbows, medial to the bicep muscles at the antecubital crease. Call this 2 plus bilaterally. Okay, go ahead and stand up on the floor. So he is not comfortable with removing any further clothing, but the femoral pulses are located deeply between the anterior superior iliac spine and the symphysis pubis, which is about here. Next, I'll have you lay down with your knees bent. Next, I'm going to palpate the popliteal pulse by putting both hands in the popliteal fossa, the area behind the knees. I would consider this 1 plus bilaterally. Now I'll have you sit up and face the door. Bring your feet up to the edge of the couch, just like that. To assess the dorsalis pedis pulse, I'll place my fingers on the dorsum of the feet, which is Lateral to the extensor tendon of the big toe. On him, I'm really only able to feel it very lightly in this area between the first toes. So I'll call it 1+ bilaterally. Now, I'll have you, flare your feet out like kind of like that. Perfect. I'm going to assess the posterior tibial pulses by placing my fingers behind and below the medial malleolus of the ankle. I'll call it 1+ bilaterally. Now I'm going to assess the temperature of your legs. You can leave them here by placing the backs of my hands along the feet and legs. Temperature is warm bilaterally on both legs and both feet. Finally, I'm going to assess for edema or swelling. We grade edema on a scale that spans from 1+ to 4+. 1+ is barely detectable. 2+ is slight indentation with a 15-second rebound. 3+ is a deeper indentation with a 30-second rebound. And 4+ is a deeper indentation with a rebound that's longer than 30 seconds. I don't assess any edema at all, so I would rate that as a 0 or a 1+. This concludes my cardiovascular and peripheral vascular assessments. Thank you for your time.